Hi, everyone. Thank you so much for joining the Foundation for Peripheral Neuropathy's first ever summer education series. We're so grateful to have your time and attention for the next hour as we dive into today's session, Unraveling the Basics. Here at FPN, we're dedicated to improving the lives of those affected by peripheral neuropathy through awareness, education, advocacy, and research to advance the discovery of new therapies and one-day cures. Your participation today helps us demystify what it means to have neuropathic pain and make our patient community more aware of and engaged with their diagnosis. My name is April Hubert, and I am proud to serve as the webinar moderator and Director of Development here at the Foundation. Thank you again for tuning into our summer web series, session number 1 of 6. It is my honor to represent the premier resource for information, research, and advocacy surrounding the individual and collective experience with peripheral neuropathy. Before we begin today, I have 3 very quick reminders for you. 1, yes, this session is being recorded. It will be emailed to you after the program and also posted on our website in the coming days. The slide deck will also be available to you. Number 2, for those participating in the live session today, we will have a Q&A towards the end of our time together. Be sure to use the questions box to submit your questions, and we'll try to get to as many as possible. Please submit questions about today's topic and refrain from sharing personal medical information. And number 3, if you are having audio issues, you can dial in by phone using the instructions sent to your email. Remember, this session is being recorded and you can view it at a later date as well. Now, I am pleased to introduce our guest speaker for today. Vanessa Tiongson is a board-certified neurologist and assistant professor at Mount Sinai Hospital. Dr. Tiongson did her neurology residency at NYU and obtained her medical degree at SUNY downstate. She completed her neuromuscular medicine and EMG training at Montefiore Medical Center. She specializes in peripheral nerve, neuromuscular junction, and muscle disorders. Within the American Academy of Neuromuscular and Electrodiagnostic Medicine, Dr. Tiongson is currently a member of the Quality and Safety Committee and previously participated on their professional practice committee. She has a ton of expertise in treating and managing conditions such as diabetic neuropathy, chronic inflammatory, and I'm going to get this one wrong here, demyelinating. How about that? Polyneuropathy and neuropathy due to ATTR transithian amyloidosis. I'm learning a lot of new terms today. So please give a warm welcome to Dr. Tiongson. We're so grateful to have you today, and the virtual floor is now yours. Thank you.
Thanks so much for your introduction, April. I'm so excited to, provide all of this information to you guys about peripheral neuropathy, and I hope that it'll be really useful for you all. So we're really going to try to start as basic as we can with regards to an introduction to peripheral neuropathy. So just some information about the word peripheral neuropathy. The word neuropathy, obviously the beginning portion, neuro, comes from the nerve or the nervous system, and pathy, you'll notice it at the end of many words used in medicine, and it comes from the word pathos, which just means, it's a suffix in Greek meaning disease. So neuropathy is a disease of the nerves. So what is the nervous system? So let's go back and just talk about what the nervous system is. So it's one of the systems of the body. It's really the command center. So what it's going to do is it's going to observe what's going on inside the body, outside the body, and command the body on how to respond to it. So what are the parts of the nervous system? First, there's the central nervous system, which we're not going to talk about too much today, but that involves the brain and the spinal cord. And then there's the peripheral nervous system, which is what's outside of the central nervous system, but it's important because those are the nerves that travel between the brain and the spinal cord and the rest of the body. So what is a nerve? A nerve is a bunch of fibers that conduct electrical signals, and they help communicate between the brain and the rest of the body. Basically, they take in all of that information that's coming from the outside world, and then they send it to the brain, and they also help provide information from the brain to the rest of the body. So obviously, if anything goes wrong with it, it's problematic. So within the peripheral nervous system, there's different parts of the peripheral nervous system. So this is important to understand what, all these parts do to understand what happens when things go wrong. So within the somatic nervous system, which is a division of the peripheral nervous system, there's sensory nerves and there's motor nerves. So the sensory nerves, they gather information from the environment. So, it can feel touch, it can feel where your body is in space, it can feel pain, it can feel temperature. Those are the types of information that your sensory nerves gather. And then output, you'll find that, the somatic nervous system, the motor portion, that will tell your muscle to move. And, without these inputs and outputs, your muscles and your sensation won't work properly. There's also another division of the peripheral nervous system known as the autonomic nervous system, which controls, a couple of divisions. One is the sympathetic nervous system, which is our fight or flight response, and then there's the parasympathetic nervous system, which is more of our rest and digest part of the system. So the autonomic nervous system isn't affected as often in peripheral neuropathy, but it can be involved in some cases. So we can talk more about that later. So now that we've learned what everything, in the peripheral nervous system does, now we're going to start talking about what happens when something goes wrong. What happens when these nerves start to get damaged? So sometimes there's these sort of myths where people think, oh, there's these terms where people will be like, I'm nervous, or you're getting on my nerves. Now, these things are not really related to peripheral neuropathy, not exactly. So usually it's more of these things that I discussed with the somatic nervous system. The sensory nerves are in charge, I told you, of, like touch, pain and temperature, and your ability to sense where you are in space. So when they're not working, you'll start to feel things like numbness, you'll feel a lack of sensation, or you could start to feel tingling, which could resemble kind of like an ants crawling on your fingers or your toes. So the large fibers actually control the where your body is in space, as well as light touch. When the large fibers are affected significantly, this also impairs your ability to tell where you are in space. So that can result in feeling imbalanced. In particular, you might notice that when your eyes are closed, you might not have a good sense of balance, or when it's dark, because you won't have those signals from your body telling where you are. As opposed to the small fibers, they control pain and temperature. And so when they're not working, sometimes you won't feel temperature well, but sometimes you'll feel excess temperature. You'll feel a burning sensation, or you might feel hypersensitivity, or you'll feel things in a way that you shouldn't feel them. For example, one complaint that many of my patients have is that when they're trying to sleep at night and their sheets touch them, it feels terrible, it feels painful. These sheets should be soft, but sometimes they might make you burn more, or they might actually feel sharp or uncomfortable. So some people actually with neuropathy, they'll want no sheets on, and others want socks on to sort of dampen the sensation that they have. So these are some of the main symptoms you can have from kind of the sensory areas. It can also result in weakness as well. In the autonomic nervous system, when this is affected, it can result in symptoms like dizziness. Dizziness is probably the most common one. Sometimes it can affect the heart rate, and sometimes it can be have an effect on diarrhea, constipation. Some of these other items are affected less often, but they do happen as well. So, we've talked about what the nervous system is, what happens when things go wrong, but why are these things going wrong? And this is important because this will affect treatment a lot. Why aren't my nerves working properly? What is damaging them? So the first cause is really diabetes. That people will joke that diabetes is like the first, second, third, fourth cause of neuropathy, because it really is the most common cause by far. And it can cause a lot of different patterns of neuropathy. They say that 25 to 50% of patients who have diabetes are going to develop neuropathy, and then the longer you have diabetes, the more frequent and the higher the frequency of the symptoms and the more severe the symptoms can get. And if you've had giant fluctuations and worse control, that also increases your risk. And this has to do with the sugar and its effect on circulatory processes. So what are the other causes of neuropathy? There are a lot of other causes of neuropathy. I won't get into detail on all of them, but I'm going to go through a lot of them in a few minutes. So number one is diabetes. Number two is actually vitamin B12 deficiency is the biggest one. So, you know, it's not a bad idea for people to be on a multivitamin, because there's a lot of deficiencies that can cause problems with your nerves. Vitamin B12 is the most common. There's a couple that can cause both a problem when they're deficient, but they can also cause a problem when they're in excess. So it's not a bad idea to make sure that you have kind of a diverse regimen of foods, and that you take a multivitamin. Vitamin B12 is actually primarily found in red meat. We don't necessarily recommend that people eat more red meat. It is possible to get it from, you know, just a supplement. Sometimes if you have issues with digestion and vitamins aren't absorbed properly, sometimes it might be useful to get like a vitamin B12 injection. Other causes include autoimmune disease. So what does the word autoimmune disease mean? It means basically the immune system is supposed to attack, you know, viruses, bacteria, foreign objects that are going to cause us harm. But sometimes our immune system, unfortunately, starts attacking us. It starts attacking our nerves. And when it starts attacking our nerves, it can cause nerve disease and neuropathy. And there's different kinds. There's a few that are focused particularly on neuropathy, like Guillain-Barré syndrome can sometimes occur in response to a virus. And that's kind of more of a rapidly developing neuropathy. And then there's other types that are associated with common autoimmune diseases like lupus or rheumatoid arthritis. But there are many, and they also cause their own patterns of neuropathy. Some cancers can be associated with neuropathy. I don't want you to think that, you know, automatically if you have neuropathy, you need an extensive cancer workup. These are probably lower down in the differential in terms of things that cause neuropathy, but there's a few blood tests that your neurologist might send to rule out a couple of these things out. And if there's risks or other things going on in your lab work, they might consider additional tests. There's many infectious diseases. Lyme disease is a big one, HIV, and then sometimes in other foreign countries, HTLV or leprosy, and shingles causes kind of more of a local nerve disease. Some medications, in particular chemotherapy medications for cancers, need to be monitored because some of them have a high rate of neuropathy. Occasionally antibiotics, but not a majority. Also, you'll have to watch out for alcohol, like especially in excess. It can certainly affect the nerves, as well as some toxins like mercury and lead. Another potential source is your genetics. Some people, they have genes that are going to make them have neuropathy, so sometimes genetic testing might be considered in the workup. Also, injuring a disease locally, that could be due to a trauma, that could be due to some sort of surgery, a compression, or if there's not lack of circulation due to vascular disease, these can locally injure a nerve. Sometimes you'll see the word idiopathic neuropathy as the cause, but this is just a fancy word for they don't know what's going on. Idiopathic always means I'm not sure. And unfortunately, we don't always find the causes of all the neuropathies. So sometimes, you know, we'll do an extensive workup and we might not know what the cause is at the end. And this does happen not infrequently. So when we're trying to evaluate a person for neuropathy, there's a lot of questions your neurologist might have. So they're going to ask you a lot of questions. And what are we trying to figure out? You know, as we go through our questions, we're trying to figure out, do you even have neuropathy? Is neuropathy the cause of your numbness or your weakness versus something else like the central nervous system or something vascular? So we're going to ask a lot of questions to try to figure out that. Also, we might want to figure out, you know, where is the neuropathy that you have? Is it due to something local? Is it due to something generalized? So we're going to ask, like, where exactly are you numb? Are you numb here? Is it all the time? Is it sometimes? And then also we'll be asking some questions that can help us try to figure out the cause, because if we figure out the cause, we can help determine the treatment. So when you go to your neurologist, they really should ask you a lot of questions. So don't be surprised about that. They're going to ask you about what kind of symptoms you have. Is there numbness, tingling, burning? Is there electrical sensations? Do you have weakness in any of your limbs? Do you have problems with your balance? Do you have dizziness? They might ask you, like, when the symptoms are worse. You know, the funny thing about neuropathy is that, you know, your neuropathy symptoms tend to get worse actually when you're doing nothing, when you're doing less. It does tend to get worse when you're trying to sleep, when you're trying to get rest. They start getting fired up, and that's when they tend to burn the most, unfortunately. Also, when you're doing nothing, when you're just trying to sit around, watch TV, you're like, why is it bothering me now? I'm trying to relax. Unfortunately, that's just something that neuropathy does. That's kind of actually more characteristic of neuropathy to occur than when you're resting, as opposed to other times. Your doctor might also want to have a timeline of when your symptoms occur. Like, you know, if you have neuropathy symptoms your whole life, for example, we might want to send genetic testing, because, you know, if you were born with it, then it's more likely to be genetic than something else. Then also they might, you know, if the symptoms are developing rapidly, like that, you know, the symptoms were minor and now they're really severe, we might be more aggressive about a workup. And then other things that we might want to know about your medical history. Does anyone in your family have neuropathy or any medical conditions that could point to the cause of your symptoms? We might want to know about your medications or anything you might be exposed to, alcohol use. So there's so many questions that your doctor should ask when they're trying to figure out what's going on. So after we get a history, we're going to move on to the exam, and we're going to, you know, for a neurologist, the exam is so important to us because we're trying to figure out where's the problem. So our exam is different from your traditional physical exam. So what you'll find that your doctor is going to do is they're going to test your strength of your muscles. Like, are you weak anywhere? Could there be a motor nerve problem? Also, you know, they might do an extensive evaluation of your sensation. So, you know, we'll test your sensation to light touch, but they might test your sensation to pinprick, temperature, or even something called vibration, where they actually take a tuning fork and put it on your skin. It's a funny thing with the vibration. It's like what vibration is testing is actually your ability to feel where you are in space. So when you feel the vibration, you're you know, whatever they're testing, whether it's your toe or your finger, it's moving the slightest amount, and they want to know that you can feel that. If you can't feel it, it might be a sign that that's contributing to, for example, a balance issue. Also, they might be looking to see if you can tell where your toe is in space. They might move it up and down to try to test that same modality. Also, they'll be, you know, touching your skin, and they'll also make note of whether or not, you know, you're hypersensitive or if it's painful to touch anywhere. So those are all the kinds of modalities for sensation that might be tested on an exam. Another thing that they'll be testing is reflexes. So usually decreased reflexes are more frequently associated with neuropathy as opposed to brisk reflex or fast reflexes actually tend to be associated more with issues in the spinal cord or the brain. So that's another thing they'll be looking at. Also, they might be looking at, the bulk of your muscles. For example, this foot that you see down here, it has a high arch, as you might see, and then it has these hammer toes. So this is the kind of foot that you'll see in certain patients who have neuropathy, and this usually is a sign of a long-standing neuropathy. Sometimes a foot like this might make a doctor want to test more for something like a genetic condition. So those are the things that we'll be looking out for on exam. So after we're done examining, we might consider some tests. And then we'll also be looking for, what patterns you might have. So with the patterns of neuropathy, we'll want to know exactly where you might be numb or weak. Like if it seems like it's only in a certain area, then it might be due to, for example, like a nerve compression, or if it seems like there's multiple nerves involved, it might be more suggestive of an autoimmune disease, or if it tends to affect the parts of your body farthest away from the center, that's more your traditional neuropathy. Like there's a variety of conditions that can result that way. Diabetes often presents that way in a neuropathy where the toes get involved first and then it creeps slowly up the legs, and then once it hits the knees, it might start to involve the hands. So there can be different patterns. Sometimes with small fiber, it can be anywhere. We also watch out for autonomic involvement, which is sort of a separate issue, but if there is autonomic involvement, for example, like you're getting dizzy and your blood pressure seems to drop with rising, we might be more concerned about something like diabetes or Guillain-Barré. So once we've completed our evaluation and we're considering a test, we might decide to do a test known as the EMG. So this is what we refer to when we say EMG. So the EMG is kind of like the lay term we use, but it actually has two parts to it. One is the nerve conduction portion, and the other part is the actual EMG, which stands for electromyography. So the purpose of this test is really to evaluate the nerve and muscle function, and it's performed really on the arms and the legs. There are some tests that we can do on the face and the back, but you'll find that a lot more of the test is going to be done on the limbs. So what type of information is your doctor going to obtain from this test? What do they want to know? Why are they doing it? So one of the things it can do is it can confirm that indeed you do have a neuropathy, and that might be the cause of your symptoms. It can also test for pinched nerves, for example, a pinched nerve like carpal tunnel syndrome, or a pinched nerve in your back, which is known as lumbar radiculopathy. It can also tell us what type of neuropathy you have. This is some medical jargon, but sometimes we'll use the word axonal versus demyelinating. And then, we really do want to know which type it is, because it will actually significantly change the type of workup that we would do. Like axonal, we might not do as much workup as we would do for a demyelinating condition. It can also help us assess the severity of disease. Is it a mild neuropathy? Is it a severe neuropathy? And if there's a severe neuropathy that's developing, excessively fast, we might be more aggressive about work. This test might not have all the answers, but it's important for us to try to figure out what's going on. So some complications of the test, it's really a low-risk procedure. Probably the biggest thing that you'll experience with this test is some discomfort. There is a risk of bleeding because we are using, a needle for a part of the test. And then also with the use of the needles, there's a risk of infection. I've never really seen any infections or any major bleeding of any concern. And then after the test is completed, you might have some muscle aches, but you usually are able to go about your day as normal. How do you prepare for this test? You should ask your physician if there's anything you need to do. When you do the test, there's going to be a lot of things that they're going to want to stick onto your skin, like stickers or tape. So you want to shower mostly to clean off any sort of residue so that, you know, whatever they want to stick on your body sticks. For that reason as well, you don't want to wear any lotion or moisturizing agents, because if your skin is too moisturized, like the electrodes and things will start falling off, and it makes the test more difficult. Like, also, you know, usually you're going to be asked to take your medications as usual unless you're directed by your physician. There might be some situations where they might tell you not to take something. Before the test, you want to make sure your physician knows that if you're on any blood thinners, because it might change where they do the test. Like, for example, they might not want to do needles in certain parts of the body if they know you're on a strong blood thinner like Eliquis or Xarelto. Usually aspirin or Plavix, it's not too much of an issue. Also let the doctor know if you have a bleeding disorder or a pacemaker. The pacemaker is not an exclusion to doing the test. It doesn't change a majority of the test. There's a few electrical stimulations, though, that they might not want to do if they know you have a pacemaker. So these are things that you just want to let your doctor know beforehand. So what actually happens during the test? So there's, like I mentioned, there's two parts. The first part is the nerve conduction studies. So during this part of the test, first they're going to stick some electrodes on your skin. So you see these, the blue, not the blue, the black and the red, those are the recording electrodes. The green is the ground, and then this device here is known as the stimulator. So from the stimulator, that device is going to deliver any sort of electrical impulse during the test. So these two little prongs, that's what's delivering that little bit of electricity. So what happens during the test is that they're going to take this probe and they're going to put it on one of your nerves, and they're going to give you a small electrical impulse. So it's going to feel kind of like a static sensation. After that impulse goes, if your nerve is working properly, you'll feel that impulse kind of travel. And then depending on what muscle or nerve they're activating, you might feel your muscle jump a little bit. So that's what it'll feel like. It'll usually feel like a little static sensation. And then these recording electrodes are connected to a computer, and then on the screen a waveform will appear. And then the doctor will be looking at this waveform to determine, you know, the heights of the response. You'll also see the doctor will do some measurements because they're trying to figure out the speeds of your nerves as well as the strength of the response. The second part of the test is the part that we actually call the EMG. It stands for electromyography, which is basically, you know, in the same way that with an EKG and electrocardiogram, we're looking at the electrical activity of a heart. Here we're looking at the electrical activity of a muscle. So what happens during this portion is that we actually have to insert a needle, a small needle, into the muscle. So the needle is a little bit long, but the needle itself is pretty thin. And so the needle gets inserted into the muscle, and this is connected to the computer as well. For this portion, you'll hear a little bit of noise. So the doctor will have to move the needle, and then you'll hear some noise in the computer. Don't be surprised by it. And then while the needle is in, the doctor will ask the patient to activate the muscle that the needle is in. And that provides information about how that muscle is doing. And so that will probably be the noisiest part of the test, and the doctor will be listening for some of the characteristics. And then that information will help us try to figure out, you know, if there's a nerve or a muscle problem going on. So the biggest question that people ask is this test painful? A lot of people get very nervous about this test. I will say, you know, with regards to this test, you know, I'll let like medical students or practicing, you know, people who are training, practice the nerve conduction studies on me and the EMG test on me. It doesn't feel that nice. You know, it's not a comfortable test. But I would say that it's usually just discomfort. It's not usually outright pain, especially with the nerve conduction test. It feels like a little static sensation. And then, you know, it's kind of more surprising than anything. It's just that you're not anticipating that you're going to feel this weird static sensation, so it surprises you each time. And then also sometimes, you know, when your muscle jumps, you're like, oh, I didn't do that. So I feel like it makes you feel a little bit out of control. But then, you know, honestly, you get used to it as the test goes on, and it's not so bad. Sometimes it's more uncomfortable if your nerves are a little hypersensitive, but usually the discomfort for this portion is pretty minor. For the EMG portion, it's a small needle. By that, I mean it's like a thin needle. So it's thinner than the needle that they use for blood draws and things like that, but it's a little bit thicker than the one they use for acupuncture, although a lot of people will compare the thickness of the needle to an acupuncture needle. Because it's pretty thin, when they do the prick where they put the needle in, honestly, that part, a lot of people barely feel. Probably the part that's a little painful is when you actually have to activate the muscle while the needle is in. And then even then, it's usually a little bit painful. A lot of patients will tell me when the test is done, oh, that wasn't as bad as I thought it would be. But, you know, there's a variability of responses to this. So other things to know about the test, it's usually done by a physician, tends to be a neurologist or a physiatrist, and sometimes they'll also have a technologist who will do the beginning portion, but the physician should usually do the needle portion of the test. It usually takes about 60 minutes, but sometimes it might be shorter, sometimes it might be longer, just depends on how much of the test there is. You know, a lot of times, like the number of nerves, the number of needles that need to be done varies depending on the problem and, you know, what information they found each step of the way. So usually they can't give an exact estimate of how long the whole test will take when they start, because sometimes if you test one thing and it's abnormal, it leads to you testing something else. But in any case, usually it's around 60 minutes. Other things that you might want to know is that they actually might warm you for the test, because the test is best performed at a certain temperature. If you're too cold, it might make your nerves fall asleep too slow, and it might make the test inaccurate. So they might need to have you warm your hands in warm water or put a heating pad on you or something of this sort. Also be aware that, you know, you might want to make sure that you wear something flexible, like something you can easily take off and put on, because you might need to change into a gown. They need to access your feet or your hands or your back. It depends on what the test, which test they're going to do. After the test is kind of completed, the physician doing the test might give you some of the preliminary results. And then, you know, it might take them a little while to write a report, and they can send this to your referring physician. So that's the nerve conductions in EMG, which is a major part of the workup for neuropathy. So there's other tests that the doctors might consider doing. So the blood tests that they send, usually they'll start out with evaluating for diabetes, B12 deficiencies, and some tests to rule out multiple myeloma and other blood disorders. If those tests aren't revealing, they'll send other tests depending on, you know, your risk factors. For example, if you're an avid hiker, they might send Lyme disease, or, you know, if you have you know, other risk factors, they might consider other workup. Genetic testing is something they might consider as well. This can sometimes be a saliva sample, sometimes it's a blood sample. This can sometimes be sent to your home or done in the office. Usually it's not done that quickly, because most doctors want patients to have significant counseling with regards to genetic testing. You know, if you find a genetic abnormality, it's permanent for you in terms of, you know, implications. And then also you have to keep in mind, you know, if you want to have children, or, you know, if you have other family members, it can influence more things than one person can realize. So that's the reason why counseling should be done prior. Some other tests that might be considered. So I mentioned earlier before that the EMG test can tell if something's axonal versus demyelinating. Sometimes if you have a demyelinating pattern on your EMG, some doctors might decide to do a spinal tap. The reason for this is that it can sometimes be useful for diagnosing something like CIDP, which is an autoimmune condition, or paraneoplastic syndrome. And then these, if you diagnose these conditions, it significantly changes treatment and prognosis, because there's more that you can do about these particular conditions. Other tests that might be considered would be like a skin biopsy. If a patient has like a whole, an EMG that's normal, but then they're having a lot of burning, tingling, suggestive of a small fiber neuropathy, a skin biopsy might be considered to evaluate if that's the cause. Also, if, for example, like there's some concern that you might have something like amyloidosis, they might consider a skin biopsy as well. And in fewer instances, you might also consider a nerve biopsy if you really want to be aggressive about figuring out the cause, particularly if it's something that's causing a lot of issues for the patient. So that's what the workup looks like. So thanks so much for listening, and I'm free to take any questions.
Wonderful. Thank you so much, Dr. Tiongson. Really appreciate all the information that was shared today. This was great. I know I learned a couple of things here. We do have some questions that have come into the chat, and a few that were sent before the webinar began, so I'd like to go ahead and get to those. So the first question here comes from Jane, asking, if you have been diagnosed with severe diabetic neuropathy, is it worth it to have another EMG in a few years, or would the test just not show anything new in the next couple of years? What would be your take on that?
I mean, I guess it sort of depends on the situation. Like, there might, repeating an EMG is sometimes useful in figuring out if things are worsening. But sometimes if you already know the cause and you know that symptoms are escalating for a certain reason, it might not always be useful. It's hard to know. It varies depending on the situation, though.
Okay, sounds good. All right, well, this next question comes from Dieter, who notes here that they were diagnosed with chronic idiopathic axonal polyneuropathy. So he asked if stenosis, can stenosis potentially be a cause? They note that I am ALOS pre-diabetic. What would be the interplay there with PN? There's a lot of terms there, so I hope that was clear.
So I think that I had a slide where I mentioned the word idiopathic neuropathy. So this is sort of synonymous with what he's discussing as his diagnosis. I mean, it basically means that they're not positive what the cause of his neuropathy is. If you're pre-diabetic, sometimes they might say, okay, it might be a little bit of that. Stenosis isn't a cause of neuropathy. Like stenosis, he's probably referring to like stenosis of the back or something like that, like a pinched nerve in the back, something along those lines. Stenosis of the back doesn't cause neuropathy, but it can sometimes cause, kind of radiating pain down the leg. It can also cause numbness in the distribution of the nerves in the back. It's not usually in kind of a symmetric distribution if it's due to like spinal stenosis, but it can worsen symptoms to some degree, because if your nerve is pinched, that nerve is working less well, and so it might exacerbate the symptoms, but it wouldn't necessarily cause the neuropathy. But it sounds to me like they're not sure what the cause of the neuropathy is. There could be some contribution from the sugars.
Okay, wonderful. Thank you for that. I'm learning so many new terms today, so just please be patient with my pronunciation here, everyone. So we have another question in here from James, asking if and now it just went away, one second. Do the medications used with multiple myeloma make peripheral neuropathy symptoms worse?
So some of them do. Some of them do. Yeah, I have seen patients who have received chemotherapy related to multiple myeloma develop a significant neuropathy, not so much from the myeloma, like myeloma in itself can cause a neuropathy, but a lot of the, there's like a few medications for multiple myeloma that are neurotoxic. I think I remember one patient who was on bortezomib. I can't remember all the chemotherapy drugs offhand, but there are various chemotherapy drugs that are neurotoxic, so they can cause issues. I know the platins, vincristine, I don't know if those are used for myeloma, but those are some of the other chemotherapy drugs that are neurotoxic as well. You know, when I've seen the neurotoxic issues related to multiple myeloma, it ends up being very, like there's a lot of issues with balance and pain.
Okay. So speaking of pain, you had talked a little bit about the testing that can be done to diagnose peripheral neuropathy. So can you share a little bit, this question is from Janice, about why a nerve conduction study would be done versus an EMG?
Usually you automatically do both. So it's like you're doing the nerve conductions, like both. The two tests together help you test like nerve and muscle function. You know, in terms of like the nerve conductions are a very important part of the EMG test. And when a doctor orders an EMG, they say EMG, but they actually mean both. So they're probably not saying that they're going to do only the EMG. They probably mean they're going to have the nerve conduction studies followed by the EMG. It's just that we kind of use the term synonymously. But like the nerve conduction studies kind of tell us like how much the nerves are responding and how fast. And then the EMG tells us if the muscles are experiencing nerve damage.
Okay. Great. So we have a couple questions that are coming in here about just really hope for the future. So kind of switching gears here a little bit. So I'd love to know kind of your perspective, and we all would want to know kind of what keeps you motivated every day, because peripheral neuropathy can be such a beast of a condition, and ultimately is very painful. So kind of from your perspective, what keeps you motivated and hopeful?
I mean, there's a lot of new things going on in terms of neuropathy. It definitely depends on the type of neuropathy. It literally, like, how many days ago, maybe like within the past few weeks, a new drug was approved for the chronic inflammatory demyelinating polyneuropathy. And within the past couple of years, there's been several new drugs for the hereditary transthyretin amyloidosis neuropathy. So a lot of things have been going on. I think that as more research is conducted, they're going to be able to figure out, more therapies for more things. And diabetes is a major cause of neuropathy, and they've really advanced, in the treatment of diabetes as well. So, I mean, I think that there's a lot of hope. There's a lot of potential. I know it's variable how much pain different people have due to neuropathy, but it can be, I know, a very stressful disease. I find it motivating to see all these new developments in the field.
Absolutely. And that's something that we at the foundation, that really keeps us motivated as well. We try to share as much resources as we're able to on our blog postings and through our monthly e-newsletters, because there's so much information out there. So we want to make sure we're sharing the best and obviously the most hopeful as well. Great. Thank you for sharing. So we have some additional questions coming in here about vitamin B12 deficiency. So this question comes from Alvaro asking, can you talk a little bit more about vitamin B12 deficiency in terms of like the different levels? Can you see some clinical improvements after B12 normalizing? So the B12 levels are very low and maybe an initial blood test, and as testing occurs, does that have a direct correspondence with neuropathic pain?
So, I mean, when you have the B12 deficiency, there's some symptoms that develop, for example, the balance disturbance, the numbness, and the tingling. It's, the number associated with the B12 deficiency, like I did want to comment on that because a lot of times it says that the normal is like 220 or something, but neurologists really consider that to be more like 400 as the normal limit, or even some people even say higher than that, because patients will experience symptoms due to B12 deficiency below that. And so B12 deficiency is not only associated with just a neuropathy, it's also associated with spinal cord damage as well. And some of that damage might be permanent and some of it might be temporary. So it's important to supplement. I will say that after you supplement and the level normalizes, the result might, like the improvement might not occur right away. It might take, several months for, nerve fibers to rebuild, and as well as the spinal cord to regenerate itself. I mean, it's not, if there's some permanent damage, not everything will come back, but it does take time. It's not like you normalize, then you feel better. It's like sometimes I'll find that patients will, when the level is normal, they'll still be like, oh, I just don't feel better yet. And then I'll see them 6 months later and they're like, actually, I feel better now. Mm-hmm. So it can take time.
Okay, absolutely. Yeah, I think patience it seems like such a virtue here and can seem a little cliche, but asking a lot of questions of your neurologist and kind of keeping that conversation open can sometimes be your best medicine, for lack of a better term here. Okay, so I do want to note that there are so many questions that are coming in, and I'm reading every single one of these, so we're going to try to get to as many as we can. But if we do not get to your question today, please send us information at our info box. That information will be listed at the end of our webinar. So we see you and we hear you. We're trying to get to as many as we can. So speaking of some treatments, there's some questions in here that are asking about red light or infrared therapy that you can wear on your feet, on your hands. Have you had any success with your patients who've received any relief from these types of treatments?
I'll be honest, I'm not familiar with the red light therapy, and I hadn't, sorry for the noise. I haven't seen it discussed, at the neuropathy conference recently, so I'm not familiar with it. I'll have to do more research on it.
Okay, absolutely. So it seems like something that we can all stay tuned for, and you, of course, always check with your doctor before receiving any form of treatment. Just make sure that everything's vetted before you start something new. Okay, so there are some questions that are coming in here about treatments such as IVIG or prednisone or gabapentin. Do you have a specific experience with one over the other? But it kind of seems like every patient is different. So what kind of advice would you have for seeking different types of treatments?
So, in terms of gabapentin is sort of, it's a medication that we give for neuropathy for the symptomatic treatment of neuropathy. It has not been shown in studies to improve nerve function in any way. It's mostly helps with particularly the hypersensitivity, the burning, the tingling sensation. It's more something to help tamper down the painful aspect of neuropathy rather than actually heal the nerves. It helps you, it's basically like, for example, you might take it at night to help you sleep because a lot of times those burning and tingling sensations are worse at night. So that's the purpose of gabapentin. Now the things like prednisone and IVIG, those are for specific disorders. So IVIG and prednisone are medications that we use specifically for autoimmune type conditions. For example, we'll use it for Guillain-Barré syndrome or chronic inflammatory demyelinating polyneuropathy, which is the CIDP. So if a patient has CIDP, that's when doctors will start talking about IVIG and prednisone. And both of those have been found to be pretty efficacious for that condition, CIDP, but they kind of have their pros and cons to them. With IVIG, it's an IV medication. You're going to have an IV placed. You're going to have an infusion that takes several hours over usually a couple of days. Sometimes you'll feel kind of malaise and sick afterwards. And then there's a risk of blood clots. But I would actually consider it a lower risk medication to some degree compared to something like prednisone. Prednisone, it's like a chronic immunosuppressant that you take. It increases your risk of diabetes, bone loss. Sometimes it's needed and it works very well, but it can have a lot of side effects. Like, for example, it can cause like stomach irritation and bleeding. So everything has their pros and cons, and you'll consider each patient individually in terms of their risk and benefit. There's also, separately from IVIG, there's subcutaneous IG, which is also an option where it's not IV, it's subcutaneous instead.
Okay, great, thank you.
Your question.
Yeah, no, absolutely. So we have a couple of questions in here that are asking just to revisit some of the topics that were covered in previously. So I will just encourage all of those folks to go back and view the recording, so that way we're not repeating a ton of information here. But we do have a question coming in here from Kevin that was asking for a quick review of what a portion of the nerve does what. So I don't know if you want to pull up the slide again, or if this is something that you can just talk a little bit more about. Probably just speaking might be a little bit easier here, but kind of talk a little bit more about like the actual like anatomy of a nerve again.
I mean, I guess with like a lot of times, like nerves will start at the nerve root, which is usually at the spine, and they'll kind of like branch off and they'll form branches and then divide. In terms of like motor versus sensory, there's some nerves that are all motor, and then there's some motors that are motor sensory, and there's some nerves that are just sensory. I didn't really get into this portion, but I don't know if that was your question. But like there's some nerves that are sensory, there's some nerves that are motor, and they all go in sort of different directions. So one nerve might be sensory and another nerve might be motor. But then the same, there might be another nerve that has both functions. So I don't know if that's what you meant. Yeah, I mean, it just depends on the nerve. So different nerves have different functions. Not like there's one part that controls the sensory aspect and one part that controls the motor aspect necessarily.
No, I think that's great. I think we're all learning a lot here today. So thank you for that explanation. Okay, so we do have Tim wrote in here. It mentions that he's had 6 years of numbness in his feet, and he's had a nerve biopsy. He mentions that they took a nerve sample from his hip, and then also down by his ankle. So he has some questions about kind of like the idea behind this. Is the idea of the test that the nerve by the ankle would show something different potentially than the nerve sample higher up at the hip? Like, why would they choose two different types of samples from two different locations? Do you have any insight on that?
I guess I'm not sure. Like, I mean, we commonly do the lower leg nerve sample. I'm a little bit surprised. Like, part of me wonders if they did a nerve biopsy in the hip area or if it was a different biopsy. Because I have not seen anyone do a nerve biopsy in the hip area, honestly.
Okay.
I'm wondering if it was a different kind of biopsy.
Yeah, perhaps. Yeah.
To answer that question.
Yeah.
Traditionally, most people who do a nerve biopsy will biopsy the sural nerve, which is like in the leg, and the lower leg in the back. That tends to be the case, I guess. I mean, in theory, some like if the lower leg nerve is what happens in your typical neuropathy is that the feet get affected first and the toes, and then it sometimes ascends upward. That's one pattern of neuropathy. It's a very common pattern of neuropathy. Sometimes if a nerve is so damaged that, you know, it's very advanced damage, you can't get that much information from a sample. So in theory, if they get one more proximally, it might show more characteristic findings that will be helpful for figuring out the cause, the type of etiology. Like one of the things that we're sometimes looking for in a neuropathy is if it has something called demyelination, where like basically there's a part of the neuron called the axon, which is like kind of the branch out, and it's surrounded by myelin on the outside. That's kind of its like covering. So we'll often talk about axonal neuropathies versus demyelinating neuropathies, and demyelinating neuropathies kind of have a different treatment approach. Like often those are more of your autoimmune diseases, where like if you have a demyelinating finding, they'll be more likely to treat you with something like IVIG or prednisone. So I don't know if they took a sample more proximally, like more on the hip, that might be the intention. I haven't seen that done personally though, so I'm not sure.
Yeah. No, thanks for the explanation there. And that actually answered another question that I had of axonal versus demyelinization. So thank you for sharing a little bit more info about that. So we're coming to a kind of a conclusion of our session here, and I wanted to note that there are quite a few questions that are listed in here that are asking about treatment options, more kind of like management, daily management of peripheral neuropathy. And I would encourage all of our participants today to take a look at our upcoming sessions for the remainder of the summer web series. We have 5 more sessions that are coming up, so those will be posted up on the slides here, just here shortly. But so let's go ahead and get closed out for today. I did want to thank Dr. Tiongson so much for sharing a ton of expertise. I really learned a lot from your presentation, so thank you so much. I'm really confident that the presentation and Q&A session allowed our participants to glean at least some helpful information. And we love to hear from our PN community, so please take the survey at the end of this webinar today. This helps us learn a little bit more about the educational content that you would like to see, and helps provide us and our speakers feedback on our presentation. Also, please consider making a $25 donation to the foundation today so that we can continue to provide programs like this and expand our mission to further research, educate, advocate, and make a difference in the lives of millions of folks with a PN diagnosis. Again, this is completely optional. Whatever is personally significant to you, we know that we're confident we can put it into good use. You can use the QR code up on the screen to make a secure donation for right now. You can just use your smartphone camera if you're logging on a desktop. Our contact information and website are listed for your convenience. So please let us know if we did not get to your questions today, or you don't feel like it's going to be covered in one of the upcoming webinars. Let us know how we can help. So on behalf of the entire team here at the foundation, we wish you all health and bright days ahead. Thank you for allowing us to be a part of your PN story. Have a wonderful rest of your day, your evening, for wherever you're joining, and we'll see you next time. Thank you so much, everyone. Have a good one.